Well, it's a great pleasure to be here today, and thank you all very much for coming. I was saying to Anand, who's the key figure in organising this, it feels like Field of Dreams, build it and they will come, because this is the first time we've ever had a competence and advocacy of efficiency, and Mia was always confident we would actually get the audience that's here today, so it's great to see you. I'm giving two contributions at this exciting workshop, and tomorrow I'm going to talk about what Mia said I would talk about, which is about how you move money within a programme of care. And this is the STAR approach, social technical allocation of resources. But when we designed the conference, we thought it would be a key issue in allocation are all these questions about the constraint on NHS resources and how it's allocated. We're focusing here on England, but similar methods are used throughout the United Kingdom through the capitation formula. And I'm a member of the Advisory Committee on Resource Allocation. What I'm going to do is to talk about two natural experiments really. The first one, in the debate that goes on now about how the NHS can cope with austerity, there are these arguments we need to reintroduce user charges into healthcare. And this would help, a common argument being that it would give extra money, and it would also make people more cost-conscious in their use of healthcare. And there's one of the world's best health economists, Bevan, did this classic continuing natural experiment between the United States and Canada. I then want to reflect on the objective of the English NHS ever since it was created in 1948 by my famous namesake, Aaron Bevan, to correct the historical inequities in access to healthcare in England. And Julie Tudor-Hart wonderfully described the problem we're tackling as the inverse care law, which is that healthcare is distributed in inverse proportion to the need for it, and where we got to in that. And the issue that we confront is that in England, since the late 1970s, we've been pushing more resources relatively into places like Liverpool and Manchester at the expense of places like Oxford. But the health outcomes of the population have been widening over this time, which is a real puzzle. And I've been working with a researcher from Sweden, comparing England and Sweden. In Sweden, healthcare is organised through local government. And the reason why Aaron Bevan wanted to move healthcare out of local government was he always said that the inverse, basically to use the phrase, that the inverse care law would apply if it stayed in local government. And finally, there are these implications, which takes us back into the sort of Hellish decisions that we were talking about. So basically, to start off with, in Canada and cost control, and these are in terms of the Hellish decisions we face, all systems of healthcare try to achieve these three objectives: so cost control, equity, and high performance. And as I'm sure you know, no system of healthcare in the world does so. And typically they fail on, at any given time, one of these, and policies are in place, the reform systems try to achieve that. And even if they make progress there, it's at the expense of others. So all systems of healthcare are always under continuous reform trying to achieve that. Now, a common view, the first thing I want to look at is this question about how does equity relate to cost control? And if you achieve equity, do you actually lose? Is this at the expense of cost control? And as I say, the key figure who's contributed to this so effectively and writes in a wonderful style, clear style, is Bob Evans. And what he did was to take advantage of the natural experiment between Canada and the United States, whereas in the 1960s they were both very similar in the way they were organised in terms of hospitals, private doctors, fee-for-service, many insurers, incomplete coverage and co-payments by patients. And what Canada did was, over a long period of time, to get alignment between the provinces and the federal government, was to introduce universal coverage. And it was all on grounds of equity. So you move to the government being the single payer for healthcare, universal coverage free for patients, but you don't do anything really to the organisation of healthcare that stayed the same. So the question is, what do you think would happen to costs? And as my friend and colleague, first in a thing called pub economics, which is it's one of those things that's always obvious and always wrong. But pub economics would tell you to expect that, of course, because health, I mean, a lot of economists get deeply anxious about making anything free, but it will lead to excessive use. And by going from incomplete to universal coverage, you're covering more of the population. Therefore, pub economics means that the costs of Canada must escalate because it's free and you're covering everybody. United States, at any given time, 25% don't get coverage for healthcare, and you have some of the highest user charges in the Western world. And of course, we know pub economics is wrong because that's what it looks like. This is Canada, so it's been able to successfully control costs of healthcare ever since universal coverage introduced in 1971. The United States has escalated as the highest spend of country's GDP in the developed world. And Evan's argument is actually what Canada did was they moved towards the system we have, universal coverage, financed through taxation, free as point of access, on grounds of equity. And they developed a phenomenally effective system of cost control. And that's because the government, the real problem you get in controlling costs of healthcare, as he reminds us, every dollar of expenditure is a dollar of someone's income. So whilst everyone's tremendously keen to control healthcare costs as expenditure, you get tremendous opposition to controlling incomes of those who work within the healthcare sector. That's the problem, of course, they have with any attempt to reform US healthcare, is the powerful lobbyists who get huge amounts of incomes out of the system. And by user charges, he says it's completely wrong because the people who really make decisions of healthcare are not the patients but the doctors. There's asymmetric information, so you want to get into the supply side, and by making the government a single payer, they're much more powerfully placed to negotiate with those who supply healthcare. So that's, it's worth remembering that, because these ideas keep coming back about shouldn't we introduce user charges for healthcare. But what I'm going to dwell on more is this question about equity in healthcare and universal care. This is due into the heart. On his website, he has been doing the tango with a very attractive young woman. He says actually he's never been able to do the tango. This is what he wished to do in his dreams. And he came up with this wonderful phrase. And he acknowledges that the paper is not evidence-based as such, but basically it's a wonderful expression that availability of good medical care tends to vary universally with the need of the population served. And so, Aaron Bevan, in a speech in 1946 introducing the NHS bill, talked about these three barriers to access: ability to pay, distribution of GPs, and distribution of hospitals. So in 1948, they did make access free, financed through taxation. They had a medical practice committee to control the supply of GPs, so they weren't able to go into over-doctored areas and in a negative direction. But they did nothing at all to tackle the distribution of hospital resources. And in fact, that became more inequitable because they continued the process of incremental budgeting. So a hospital that was relatively underfunded in 1948 would continue to be underfunded in the following years. And they took teaching hospitals out of the regional stretch against boards of governors, they recruited the most able staff, direct access to ministers, and actually inequity got worse and London continued to get vast amounts of money because of its 12 teaching hospitals. I think the explanation for that is Lord Moran, with whom Aaron Bevan struck up this powerful alliance. President of the Royal College of Physicians, the BMA opposed the NHS, Lord Moran supported it with skillful political support, they delivered the NHS. I think that's the reason why they actually didn't do anything about hospitals and privileged teaching hospitals. I was actually brought up in Oldham, and after having been to another, where Muffins Institute in Oxford was before, which was a new medical institute when I was there, I was able to go and move to Hampstead. And when I was working in Walter Holland's unit at St Thomas's Hospital, the Department of Health introduced these measures of spend per capita and performance indicators. And Hampstead spent 3 times per capita than Oldham. So that's in the 1980s. So the inverse care law was still very much alive and well in England in the 1980s. And the work had already begun through the Resource Allocation Working Party to try and move resources to correct the inverse care law. And obviously the way the formula works is you start off with a total budget for England, you adjust for the crude population, you then have to adjust for need within the crude population, And the first thing you do is age. As it turns out, in terms of the statistics, sex distribution doesn't matter. Age obviously does. And this is the age cost curve in 2008 for England, showing that there isn't, I mean, it all matters when you get into the elderly population. These are different programmes of care, and that's the relative spend by age group, with this dramatic increase. Now, Australia itself is riding at the age cost curve at the moment, actually. But the thing is, if you were to adjust for age solely in the formula, and this is this famous comparison between these two areas in Glasgow, a few miles apart, Lenzie North, the life expectancy is 82, and Colton, the life expectancy is 55. If you adjusted for age, then clearly, given this age cost curve, Lenzie North would have much more per capita than Colton. So just putting age adjustments into the formula is not good enough, so we have to have some other measure for additional morbidity. And the Resource Allocation Working Party talked about additional need using standardised mortality ratio, which I still believe, along with others, is a very good measure of need for healthcare. They wanted a measure of need that was independent of supply, because if you use data on utilisation, it will reflect the existing distribution of supply, which they knew was heavily inequitable at the time. The problem is, whilst SMR is a good indicator, or mortality is a good indicator of relative need in populations, as a proxy for underlying need that you treat. We're not saying that by spending money on healthcare you reduce mortality, but it's an indicator of need in the population. How much more should you give, for example, with an area that's got an SMR of 110? So it's got 10% more death than you'd expect, given its age and sex structure. And in 1976, it's amazing, they produced this report in 9 months. We now think about it, it doesn't take that much time to make a minor modification to the formula. Produced the whole report in 9 months. And they thought the best thing they could do in the absence of any evidence is assume a one-to-one relationship. So if you get SMR 110, 10% more deaths, you need 10% more resources. After about 10 years, people became unhappy with just making this heroic assumption. And what's gone on, and this is something I'm not happy with, is the use of empirical data on utilisation. So I find it really weird, because while Wenberg, and the Dartmouth Atlas and the NHS Atlas have documented all these variations of utilisation that clearly have nothing at all to do with need, what these studies do is to use small area variations in utilisation as a way of estimating need. And what's also troubling, this shows how much you get in terms of percentage for an SMR of 110 with different estimates. So Rourke came up with 10% you get 10% more in 1976, that's the assumption. The first empirical estimate that came up in 1988 pushed that back. So you'd only get 4% extra resources. This is a review of York formula. There was then the York study that pushed it up more to 7%. There was then the area study that pushed it up even more to 8%. And then there was a Karen study that pushed it back to 4%. There's been a later one, worse than diagnosis. And it is deeply troubling. I mean, because I see these expert econometricians come and present their work and say this is state-of-the-art work, we're going to correct all the errors of the previous thing. But these numbers leap around like this. So that's a very troubling thing about it. In terms of what's happened over time, this is spend per capita adjusted for age and price by PCTs. We have to go back to PCTs because, as Muir said in the Commissioning Archipelago, we can no longer work out what the spend is on healthcare across different parts of England. It's things that troubles the advisory commission on resource allocation. But there is a very strong relationship between spend per capita and SMRs. Now this relates to the question about variation. So on the one hand, we've got this formidably advanced developed formula to try to achieve equity in spend per capita on commissioners. And then the question is, how do commissioners translate that budget that reflects the fixed budget for the NHS allocated as far as we can assess on an equitable basis into value? And as Muir pointed out, what we know is, although we try and correct spend per capita for need, so we have an equitable allocation, there's enormous variation across the programme categories in there. And the thing that Jack Wenberg's Atlas has demonstrated, and Muir's NHS Atlas has demonstrated, is enormous variation in conditions and procedures across England. So I was a co-author on a King's Fund study, which John Appleby was the first author. And the sort of things that were coming through there, in terms of things like tonsillectomies, clearly not a need-driven procedure, the high variation, the high rates of tonsillectomy are actually taking place in areas with high levels of deprivation. And the other finding was, in terms of hip and knee replacements, using data on the PROMs, patient-reported outcomes measures, if you looked at areas with high deprivation, they had lower admission rates than the areas that were better off. And also those going in for the operation were in a worse state of health. So we do have a big challenge here. On the one hand, we've got a formidably complicated formula to try and achieve equity in total spend per capita. But then once it gets spent on the providers, it goes all over the place. But one of the things that really troubles me is what we thought we were doing. Because I've been looking at this formula and used in resource again for 30 years. So in 1976, when the Rourke report came out, and I teach it to our students at LSE in policy analysis, a wonderful example of successful policy analysis that had a huge impact, changed the way the NHS allocated resources. And what we thought we were doing was simply this, that what we're going to do is pull Hampstead's spend down and push Oldham's up. But what's actually turned out is, as I said, that we push resources, we take resources out of Hampstead relatively, but its health gets better and Oldham gets worse. So we've actually had, whilst we've been trying to correct the allocation of resources on an equitable basis to meet these measures of need, we've had a widening of health inequalities, which then takes us into the social determinants of Michael Martin and Richard Wilkinson have written extensively about this. And this is why I did work with researchers in Sweden to look at what's happening in Sweden. And this is someone as spickety as Rockstall and Capital, and he actually has a doctorate from the LSE. And when he was invited to LSE, Tim Besley, who introduced him, pointed out we had another economist of Rockstall, which is Mick Jagger, actually, although Mick Jagger didn't actually complete his degree at LSE. And if you look at this talk on the LSE website, LSE inflicted on Tom what they always do to speakers, which is they couldn't get the overheads to work. But this shows 10% income share in Sweden. As you probably know, because this book's received such massive coverage, there's been a long decline in inequalities in income. So the top percentage share has fallen to 1970 in both England and Sweden, from about over 45% to 30%. Now in Sweden, Sweden was an independent country, was not affected in the Second World. This is to do with social democratic policies to try and constrain differences in income with very high rates of taxation. In England, Piketty argues this is a casual effect of 2 world wars, financing 2 world wars, inflation. It wasn't to do with specific policy, though England did have quite high rates of taxation. After that, you see this huge increase, which we've witnessed over the last 40 years in the growth in inequality. And Sweden is now some improvement, but there's still a huge gap there in terms of incomes. So if we compare equity in health and healthcare in England's NHS, and this is the spend per capita, which you've seen before. This is the distribution of GPs. This actually should be smaller in the where you've got high SMRs, you should have a smaller list size. And there's no evidence of that at all. You should have a line like that going for spend per capita, and a line like that going for list size. And clearly, it's been much more problematic for us to achieve equity in the distribution of GPs than it has in money. But the point I want to make is that if this is in 2008, the standardised mortality ratio, this is under 65, ranges from 70 to 170. That's an enormous range in terms of variations in expected mortality across the areas in England. This is the Swedish map. Now, as we'd expect, this is spend per capita. because it's done through local government, they do not have central control. They cannot move money around on an equitable basis in England. And the GP, if anything, has an inverse care law. It tends to be smaller this size in the healthy populations. But the striking thing, of course, is this very narrow gap between the SMR. So it's 85 to 110 in Sweden and 70 to 170 in England. So, what's this raise? It seems to me that there's convincing evidence that the system we've got for funding the NHS free at the point of access, as in Canada, is a very effective system of cost control. So we've got a good way of linking equity to cost control. So in terms of this iron triangle, these difficult objectives, it's good that those two march together. The issue that we've got is having a system that's designed to achieve equity in terms of access and the distribution of resources. How do we relate that to performance? For me, one of the big issues is this point about unwarranted variation. Should we really, this is not hardly a rhetorical question, I don't believe we should, be using data on utilisation to measure need? And the most recent approach used in England, person-based resource allocation, uses data on diagnoses. But there's been extensive studies by the Dartmouth team in America looking at measures of risk adjustment that use data on diagnoses that points out, again, they are influenced by supply. So if you look in areas in the United States that are very poor, then they tend to have a very low rate of supply of doctors to population. These are not profitable places to work as a doctor. And they will tend to have lower rates of diagnoses than the rich areas where the doctors concentrate. You get lots of diagnoses. So if you use these well-established methods of risk standardisation, what happens is you widen the inequalities in health, because the poor areas are tending to be much healthier than the mortality statistics suggest, because they get lower rates of diagnoses. And the rich areas are tending to be much sicker than the statistics suggest, because they have lots of diagnoses. So I think there are real serious questions about us using data utilisation, national forming, to estimate disease. And then there is, of course, this challenge, which is Mio referred to in the programme budgeting analysis. Peter Brown will be working on that, we'll talk about that. Many of you are looking at that. And also looking at variations in procedures and conditions, because thinking, how can we actually use commissioning to tackle unwarranted variation? And then in the end, of course, there are these big issues about achieving equities in health, or widening inequalities in health. At the national government level, there are questions about incomes and taxation. Do you want, and Piketty's argument is that this reduction in rates of taxation, England, going from something like 90% top marginal tax rates to 40%, that immediately puts pressure. The people, these super managers who get paid what I regard as these obscene salaries, they get paid obscene salaries because the tax rates are low. If you have very high rates of taxation, people aren't going to press for these vast salaries. So these two are related. There is this question about GPs having achieved, what looks like an equitable distribution of spend. A key point of access, of course, to healthcare is through GPs. So are there things we can do about that? And what about the NHS allocations? Putting about twice as much per capita into Liverpool and Manchester compared to Oxford, given these widening inequalities in health, you have to ask, is that really good value for money? And perhaps we should be doing, this is what the Barker Commission report from the King's Fund suggests, actually, that we better integrate health and social care before NHS in local government. But it also raises a question as to, if you wanted to tackle the social determinants of health, wouldn't it make more sense to put the commissioning for the NHS in local government so they can look across the whole range of public services and tackle inequality in that way? And that's it.